So I don't know, for those of you who weren't here yesterday, I just want to quickly say, so I'm a professor at the University of Oxford with an interest in CLL, but I also spend quite some of my time in Dar es Salaam in Tanzania, where I'm a visiting professor at the Muhimbili University of Health and Allied Sciences. And so that's why I'm having this, these two pictures, you know, the skyline of Oxford, of course, and then the Tanzanite Bridge in construction about 3 years ago. And this gap in the bridge always reminds me of all these gaps that we have to bridge when it comes to hematological malignancies. So my talk today is about access to medicine, and I'm just putting my own views to get you know, onto slide. The important thing to reiterate for especially the patients in the audience is that for for patients in high income countries, and for those who have got private insurance and for those who live in a national health system, the age-adjusted mortality has improved very dramatically since 2010 with the introduction of rituximab to the chemotherapy backbone, and then subsequently with the introduction of the targeted agents, starting with ibrutinib and the RESONATE study. So you can see on your left-hand panel the UK statistics from the United Kingdom, and then on the other side of the panel you see Italian data that shows how dramatically outcomes have improved with BTK and also venetoclax-based therapy. Now the issue is, and this is an equal area projection of planet Earth, the issue is that this is not true for most patients with CLL, and even although at the moment these disease might still be quite rare in low middle income countries, as people are progressing and transitioning into a more Western lifestyle and they're living longer and we're treating their strokes, their heart attacks, etc., we will, and managing their diabetes, they will no longer die from that, but they will actually then develop CLL. So what has happened in Caucasians, I'm pretty sure, will also happen in the rest of the world. And in China, interestingly, already people are now saying, actually, it's not that rare. It's actually more common. And because the more we are doing flow cytometry, the more we are doing routine blood tests, the more we are doing hernia operations and doing hip replacements, the more we are actually also identifying patients with CLL. So this is kind of the problem. Now, what this map doesn't show is that there is also an in-country difference to access. And whilst we are talking, and me in particular, I'm always talking about the low, middle, and the high-income countries. Actually, you know, increasingly we see disparity in our own communities, you know, in the United States and in Europe, and that is also, I think, an important point to point out. How can we get access to medicine? Well, if you're lucky and you're living in a National Health Service or some other, you know, European safe haven, the government or insurance funded following registration will basically be available, drugs will be available to you. So in the UK, we now no longer using EMA because we have Brexited, so we have the MHRA. They are the regulators. They basically say, okay, this is a medicine that is safe to use, and then there is something called NICE, the National Institute of Clinical Excellence, and they will decide whether it is good use of public money to pay for these drugs in principle. But then there's a third step, which is the NHS, and the NHS then decides, do we actually have the money at the moment? So this whole process can take up to 5 years, from EMA approval or MHRA approval now all the way to actually having the drug in the NHS. And during this time in the UK, there are access schemes. There used to be quite a lot of access schemes. Pharma is using this to get, you know, patients hooked on the drug, to get, you know, get. I'm saying this in a slightly negative way, but to get doctors used to giving the drug and to prescribing. Now, in a global scale, that also happens, and it's important to say that, you know, serious access schemes will always do like a patient-by-patient distribution. So you're not going to get a big lorry or a big truck full of medicine arriving in a country and then being distributed nilly-willy. It's basically something that happens on a patient-by-patient basis, and that is very important because you can imagine the type of abuse that can happen if you're just coming up with a big truck and you're dumping it somewhere. So there's clinical trials, and I'm going to talk about this a little bit, and the reasons for why, some of the reasons for why even in regions like South America, there might not be that many clinical trials. The use of generics, that's a legitimate use, or how we access medicines post-patent expiration, or via patent sharing. So I'm always giving the example of the HIV drugs. When the HIV pandemic hit Africa, we very quickly we find a solution, putting patents into Africa, getting South Africa to produce triple therapy in a very much quality assured way, having GDP adapted pricing for some of those drugs, which meant that they are literally for free now. This continues to happen for the 10 to 15% of HIV positive patients in sub-Saharan Africa. And they now get PEP, they get PrEP, they have a very good system in place. And then the use of counterfeit drugs. So what is important to say, when we are accessing medicines through all these different mechanisms, healthcare professionals and patient education really has to underpin all of this, because otherwise, it can go horribly wrong. So I want to give the example, and this is thanks to Mariam and Adriel from the Max Foundation, of how patient distributing programs can happen and how IWCLL is trying to support this and to underpin this. So CML, chronic myeloid leukemia, and I know some of in the audience here are representative of CML patients. The Max Foundation has distributed over 36,000, has helped over 36,000 CML patients, and a sniff of other patients who also, with other malignancies, who also benefit from imatinib treatment. They are also distributing second-generation tyrosine kinase inhibitors. So this is extremely impressive. They have a distribution system that goes into 83 different low-middle-income countries across all the continents. And the system they're using is a patient-by-patient distribution system. The CLL program with zanubrutinib started in January of this year, and this is the latest numbers, the September update. So a total of 137 patients have already been started on zanubrutinib across 3 different countries. The median age at diagnosis is 64, so probably younger than what we would expect in a high-income setting. And about a bit over half of the patients are treatment-naive patients. The others are relapse-refractory patients. And there's slightly over-representation, I would say, of female patients. And that goes in line with what certainly I know from my own practice, is that men, certainly in sub-Saharan Africa, they never get sick. I don't know why that is. Whereas the females, they get more easily sick. So there are 3 countries, Armenia, Nepal, and Ethiopia. I think Ethiopia, we will see a rapid increase as soon as this, this program becomes more known across Ethiopia, because it's the second largest, by population, the second largest African country at the moment. So what the Max Foundation is also doing and is partnering with other stakeholders. In particular, they are already partnered with 10 different global pharmas. Of course, they're expanding now their program into other indications as well. But I think we have, as clinicians, I think we really need to lobby quite hard with other companies that they join this consortium. To bring those life-saving drugs to other places in the world, because we are not talking about any drugs here. We're talking about hugely effective life-saving medication. And so within the IWCLL, we really want to underpin this with education, because nothing is, we really have to make sure that the right treatment is given to the right patient at the right time. And with CLL, as we've heard over the last couple of days, diagnostic is one of those areas where it's not always straightforward. Does the patient really have CLL? Do they really benefit from zanubrutinib? Do they really need treatment? There's a lot of gray questions that I think only the clinician on the ground who's responsible for the patient can answer. But for that, they need to be educated and they need to understand, how you manage CLL. And so that's the aim of the IWCLL, and we've started, thanks to some funding from ABVI, an online masterclass over 8 weeks, once, twice a year. And it's open to any healthcare professional, but clearly the people who are looking after these zanubrutinib-treated patients, we really encourage them to participate. We have live tutorials in 3 different time zones every week over 8 weeks, and we discuss all the ins and outs of how patients on targeted therapies should be managed. So yeah, so this is the program. Now we have to talk about this. So we have done other things, and many other people have as well, but I'm just mentioning the IWCL efforts. We provide practical training in capacity building grants. You've heard a little bit from Nora Akinola, the Nigerian grant. We are thinking of developing resource-restricted guidelines for clinicians, although this is something that I think actually has to come from national committees. And then we started also encouraging people to, the clinicians on the ground, to engage with their patients and with the general public. So to really catalyze, if you like, the beginning of patient association groups in parts of the world where that might be a very odd thing to do, and people might even be afraid to join an association because that might be linked to political activity, and in some of the repressive regimes, it's quite scary for patients. So they're sick, and then on top of that, they're now being asked to join an association, and so yeah, there's lots of issues around that, and the freedom of speech is something that is the concept of that is not always very familiar. People are not always very familiar with. So we're trying to kind of very cautiously address this as well. So there we are. So we need to manage risk when it comes to the drug distribution programs, and that includes like the programs like the Max Foundation, but it includes also any other efforts that are ongoing. And I would like to point out that for pharma in particular, the access to markets is really important, and they will not start running clinical studies unless they have an access to market. But the access to market, they need to be reassured that when patients start on drugs, that pharmacovigilance is in place, and that that they will understand what are the side effects of the drug when we are distributing or when we are selling drug. And that's a particular issue when it comes to ethnic groups that are traditionally underrepresented in the clinical trials, like people of African descent or Indian descent. So I just want to give a couple of examples why access of medicine through clinical trials is a really important one. And this was data in a comment letter to The Lancet published by Pete Hillman and Charlie Craddock. They basically took, from 2016 to 2017, 670,000 people who were recruited into over 4,700 trials across the NHS. Thanks to more than £2 million worth of annual investment into our research network that, by the way, has been dissolved and was dissolved by Boris Johnson last year. Direct drug savings from 3 of the largest clinical trials in common cancers, chronic myeloid leukemia, chronic lymphocytic leukemia, and multiple myeloma, provided access to free drug worth more than 200 million to 1,737 patients who would have otherwise had to have treatment for another 20 million on top of that. So the FLAIR study in particular provided novel agents to 900 patients that at the time were not available on the NHS, instead of combination chemotherapy that we knew at the time it was suboptimal treatment, saving the cost and toxicity of these drugs, in particular admission rate of up to 25% on FCR treatment, when patients get admitted for neutropenic sepsis and infectious complications. So this is hugely cost-effective for the NHS to run clinical trials. That's basically the bottom line, and those are the numbers. And it's just what it is. But of course, governments might not always see this. So pharma needs access to markets to run clinical trials, and there's Miguel already talked about this a little bit. I did some research on counterfeit drugs, and you can see that the seizures of counterfeit drugs in millions of tons has increased now to 500 to 25 million items or 500 tons in 2018, and it's been increasing ever since. The number of websites, of counterfeit websites closed has decreased during that time, and I think that might be thanks to some legislation that was put in place to really regulate and to police online pharmacies and to have a regulatory body overseeing online distribution of drugs. But you can see that this is it's a very important issue, and Interpol is on the case, but they're not winning. At the moment, they don't seem to be winning the battle. So possible types of counterfeit drugs. First of all, it could be no active drug, but it's also no harmful substance. So this was erythropoietin, for example, what actually was Miami City tap water. I find this quite, in a sad way, quite amusing. Some antiviral ampules were filled with normal saline. It could be excessive or concentrated active drugs, Botox in particular. Everybody knows why we're using that one. The wrong active drug, so that's kind of already quite bad. Then drugs contaminated with microbes, toxins, or harmful chemicals. So counterfeit cough syrup, for example, that was mixed with ethylene glycol, an antifreeze substance. So there's all sorts of funny things happening. Now, it's not actually an issue that is restricted to low-middle-income countries, and that was new to me. But if you look at lifestyle drugs, including Viagra in the United States, purchased online are fake in as high as 77% of cases. 1 in 10 global medicines are substandard or fake. Fake antimalarials causes mortality of up to 450,000 people per year in sub-Saharan Africa. 63 million worth of fake drugs were seized by Europol in one of their operations, and the prevalence of fake drugs reached 70% in few parts of Asia. So these are very bad figures. I was quite shocked by them when I saw this, but it seems like that this is actually the reality we are facing. So my conclusion is that it is really important that patients, healthcare professionals, and the general public lobby with their governments to manage safe access to drugs. And they could be through any of the means, whether it's access schemes, whether it's clinical trials, whether it's commercial supply, whether it's GDP-adapted pricing. There are many ways how we can access drugs. But we need to make sure that we avoid unverified manufacturing, uncontrolled supply chains, unlicensed pharmacies, and an insufficient drug safety reporting mechanism. And those things, they have to be in place before pharma will come and sell their real drug, right? Because that is, I think, the problem we are facing. And that is also the reason why, in order to get clinical trials to those countries, we need to ensure that we have a bit more of an understanding of this. So it's really up to us to lobby for this. Yeah, thank you.